Good evening, everyone. I would like to welcome everyone to Grand Rapids Community College. As you know, we're hosting the Michigan State University's College of Human Medicine's Your Health Lecture Series tonight. And I'd like to thank everyone for taking time out of their busy schedules to come this evening. And my name is Paul Krieger. I'm professor of biology in the Biological Science Division here at Community College. And I'm also an alumnus of GRCC and the coordinator of tonight's event. Our sponsors for this event are Grand Rapids Community College, Michigan State University's College of Human Medicine, and Spectrum Health. Let's just take a moment to please give them a nice round of applause and thank you. This year marks a special milestone for GRCC as we're celebrating our centennial, 100 years of serving our community. And we offer an accessible and affordable education for a wide variety of students. Whether it's for a transfer student or for a student enrolled in one of our own degree programs, GRCC is a great place to start your college education. You're sitting in the auditorium of the Calkins Science Center, which is the home of our science division, which includes the Biological Sciences Department and the Physical Sciences Department. If you'd like more information on our wonderful programs, you can feel free to examine our website at grcc.edu. Now I would like to introduce Mark Breevy, who's Director of Community Engagement and Outreach at Michigan State University's College of Human Medicine, who will introduce our speaker for this evening.
Thanks, Paul, and thank you all for coming this evening. This is the first time that we're actually doing this lecture series here at Grand Rapids Community College, and we're really pleased with the turnout for a first-time event. And I did want to specifically thank our host, Grand Rapids Community College, for providing the facility this evening. I also wanted to thank Paul again for helping coordinate this. Tina Hoxie and Kathy Novisky were all really a pleasure to work with. As Paul mentioned, Spectrum Health is co-sponsoring this event. They helped kind of get the word out as well as the Heart Association of West Michigan also helped with some of the promotion, so I wanted to thank them. Before I introduce our speaker, I want to mention that Michigan State University College of Human Medicine and Grand Valley State University have established a cooperative program of pre-medical to medical education by which Grand Rapids Community College students who transfer as undergraduate pre-medical students to Grand Valley State University, they have the opportunity to be granted an early assurance admission to MSU College of Human Medicine. And this early assurance program provides an enhanced opportunity for admission to medical school for GRCC students transferring to GVSU as pre-medical students. And they need to be interested in serving traditionally underserved populations or coming from a population that's underrepresented in the medical profession. And that program was established in 2012, and I'm happy to say we already had one student accepted through this program in the 2013 class. So if you are a GRCC student thinking about making that trek to GVSU and onto medical school, definitely take a look at that program. MSU has similar agreements as well with Aquinas College, Calvin College, Hope College, and Grand Valley State University. And now I'd like to introduce our speaker for this evening. Dr. George Abela is professor and chief of the Division of Cardiology and director of the Cardiology Fellowship Training Program at Michigan State University College of Human Medicine. He earned a medical degree from the American University of Beirut. He completed his medicine and pathology residency at Emory University in Atlanta, Georgia, and a cardiology fellowship at the University of Florida in Gainesville. Prior to his tenure at Michigan State University, Dr. Abela was associate professor and co-director of the Institute for Prevention of Cardiovascular Disease at Harvard Medical School. He's board certified in internal medicine and cardiovascular disease. And Dr. Abela's research interests include plaque rupture and thrombosis, the primary cause of heart attacks and strokes. So without further ado, I want to introduce Dr. Abela.
Thank you for inviting me here today to share some of our work and some of our experiences with you. I'd like to thank Mark and Paul for their kind introduction. I've been with MSU for almost 20 years now and running the cardiovascular training program and doing research. And my passion has always been trying to figure out problems that we see in the clinical world and trying to address those in a setting that's controlled, such as a laboratory, and trying to find answers. And I'm here today with you because of one person, actually, or several people, but primarily one person who was my chemistry teacher in high school, Gustav Klee. And he was the reason I'm here today. And I always like to feel that someone has affected our lives by being a mentor and providing some curiosity and passion towards things that you'd like to do. So what I'd like to present initially is a background as to where we are today in terms of what we understand in our current thinking about what triggers a heart attack and stroke. Now, everybody is familiar with all the risk factors for heart attacks and strokes, but the question is, what brings it on? It tends to be a bit chaotic. It tends to occur at different times. So what is it that triggers it? And then we'll describe a finding that we've made at Michigan State in terms of understanding the underlying process that brings us about. And then how do we use this finding to improve our approach towards patients? Because that's really what it's all about at the end of the day. So briefly, nationally and worldwide, today, cardiovascular disease, meaning heart attacks and strokes, is the leading cause of death. Now, that may not be true for very long if Ebola gets a better hand of us. But for where we are today, that is the leading cause of death. And that's interesting because prior to about 10 or 15 years ago, that was not the case. Infectious diseases was still the leading cause of death worldwide. But as societies have become more affluent and food becoming more available and different lifestyles have been introduced, heart attacks and stroke have taken the lead. And it is projected that over the next 20 years or so, that with the increasing in obesity and diabetes, that number will continue to rise, certainly in our society. If we look at the state of Michigan specifically, we find that the total number of deaths from heart attacks is about 35,000 per year and about 5,000 strokes. That is not an insignificant number of people that suffer from this condition. Now, what do we know already about this situation? Many people will tell you this is a preventable disease. If you do the right things, if you exercise and you stay healthy and so forth, that your chances would be greatly improved. In fact, there was a recent study that came out about a couple of weeks ago that said all you really need to do is quit smoking, exercise, walk, lose weight, do the right things, and it would reduce your heart attack risk significantly. And that's true, it would. But we all are also bound by our genetic makeup, and many of us are still going to be at high risk despite our best efforts. And many people do experience that. In fact, we have many patients that we've seen that are like that. So the current understanding of the leading causes of or risk factor for heart attacks and strokes include high cholesterol, specifically the bad kind of cholesterol, the LDL or low density kind of low cholesterol, diabetes, high blood pressure, smoking. Smoking alone increases the risk of heart disease 5 times. So I tell my patients, okay, you're still smoking and you've had a heart attack, and we're giving you a statin to reduce your cholesterol. That will reduce or cut your risk of another heart attack by about half. However, if you stop smoking, you probably reduce your risk by about 5 times. Wow, an eye-opener. But nevertheless, it's difficult. People have a hard time changing habits. Changing behavior is one of the hardest things that you can try to do. And I think all of you recognize that. We all have certain behaviors that we would have a hard time to change. So it's not a question of judging others, it's a question of how can you work with them to get them to change. And that's hard. Family history carries its weight. Sedentary lifestyle and obesity, all these are well-known and established causes or risk factors for heart disease. Heart disease is the leading cause of death, and the understanding about it is a little bit unclear because even for women, the leading cause of death is heart disease. But if you asked around and if you surveyed the female population, you'll probably find or hear that their primary concern is going to be breast cancer. And of course, breast cancer is a serious condition and also carries a great deal of risk. But the number one cause of death, both for males and females, continues to be heart disease. And if you compare the numbers, at least from the last time the survey was done here in 2003, you'll find that there's almost a doubling, not quite, but almost a doubling in the number of deaths in females from cardiovascular disease compared to cancer. Next followed by chronic lung disease, Alzheimer, and diabetes. So it's a huge issue. Now, the reason that perception is different is probably because when people die of heart attacks, they die fairly quickly. Whereas if they died of cancer, it's protracted, it's more painful, it carries a much more dramatic, if you will, element to it. And thus, the thinking is that's perhaps the most common cause, which it's not. So as we mentioned earlier, so we understand that these are risks for heart disease. And in fact, some of these risks for heart disease are shared by cancer, by the way. And we can talk a little bit about that later on. But they share many of the same risk issues. So we know what those risks are, but what actually says today this person is going to have a heart attack? What is it that says this individual is going to have a problem? And we do not have a good handle on that. And that's because the mechanism of the underlying condition is not entirely clear. So I was very fortunate to be able to work with a group in Boston that was looking at the early morning hour occurrence of heart attacks. So what they were doing a different study. This was at Harvard. They were looking at patients who had heart attacks at different times of the day. And they found that heart attacks and strokes cluster in the early morning hours. There's another little peak in the early afternoon, but the major number is early morning hour between 5 a.m. and 10 a.m. So they asked me to join the group because I model disease and I study it in the laboratory. So I joined the group with the understanding that my role would be to define the mechanism of why this heart attacks and strokes were clustering in early morning hours. Okay, so the group had already started an epidemiological type of approach to the problem. So they were trying to figure out were there associated conditions that would lead this event, to the event. Namely, would it be possible to identify a stressful event, like a sudden stressful activity the day of or before that caused a heart attack? Anger, they found, was associated with this. Sexual activity, although very small, was still associated with it. Snow shoveling is another finding. And in fact, this data on snow shoveling comes out primarily from Michigan. What can I say? Some of it may come from the cost of the gas at the pump, which keeps going up and down. I don't know where it is today. On my way in, they said it was going up, and my heart rate started to race. But the idea is that even if you took all these kind of stressors that we think lead to an acute event, they only account for a small number of heart attacks, about 18% or so. So there's this huge amount of events that are occurring for unknown or unclear reasons. What do patients who have heart attacks feel? This is a picture by Netter, and Frank Netter was a great artist. He captured a lot of the elements of which you see this gentleman coming up, grasping his chest with pain, and you'll find that he's a traveler. He's very nicely dressed. He's an executive type. It's snowing, and he's rushing from a restaurant where he's had this heavy meal, and all these things leading to his acute event coming out of this restaurant. Typically, this is what a patient may feel. The reality is about half the patients don't experience any of these type of symptoms. And that's the challenge for us in the clinical world, especially women. Women have a very different type of manifestation. Most of their symptoms are less acute. They tend to be more vague. They tend to be more discomfort. They tend to be more jaw discomfort, back discomfort, not feeling quite right. These are all symptoms that don't fit into this nice, clean picture. And we can try to explain some of that based on the findings that we've made in the laboratory. Okay, so let's go back. I'm going to take you between clinical and lab, back and forth. And that's how I think, and that's the way I work. Because we try to figure out what's going on in the clinic, we go to the lab and go back to the clinic to get more answers. And so we learned, even while I was in training, and now it's a few years, that cholesterol is a major link between heart attacks and strokes. In the past, and until about 20 years ago, and there are still some outliers out there that don't believe that that's the case, but there's no question the data is very strong now that high LDL, which is the bad kind of cholesterol, is associated with acute cardiovascular events. Now, the reverse is also true. If you reduce the cholesterol levels in the serum, as you see here, based on all the studies that have looked at, these are all titles of studies that have looked at patients by using different statins to lower their cholesterol. And the lower we go, the less the cardiovascular events. So we have very strong data. It goes both ways. If the cholesterol is up, more heart attacks and strokes. Cholesterol goes down, less heart attacks and strokes. I would say that's pretty solid scientific evidence. Would you agree? Okay. Another important discovery that was made about 20 years ago was made by Bill Little down at the at Wake Forest. And what they discovered was something that was quite remarkable, actually. So this is an angiogram where people go and have pictures taken of their coronary arteries. They have a catheter that's put in from the groin or from the arm that goes to the heart, and they squirt dye and they take pictures. And this is a nice looking artery here, you see. And there are a few what we used to call luminal irregularities, which means that there's a little bit of indentation in the vessel. We used to tap the patients on the back and say, don't worry, you're fine. You got a little bit of something there, no problem, go home. You'll be fine. Wrong. In fact, what he showed is if you follow these patients up, these are the lesions, these inconspicuous lesions that are the ones that lead to this event, which is the same patient 2 weeks later coming back with a heart attack related to this inconspicuous narrowing that has caused this event. Closure of the artery with thrombosis. This is a heart attack. So what is happening here? Why are we getting this kind of scenario? So if we look at a cross-section, if we take a blade and cut right through this area where there's a heart attack, you'll find that this is the artery, And this is the original lumen where the dye was going through very nicely earlier in the previous picture. But now we have a tear. You see there's a tear in the wall of the artery where in this part of it you see there's like a fatty material and a clot that has now obstructed the blood flow. Okay, so what has caused this artery here to tear? It's like a wound. It's a tear. And like every wound, the body does what it's supposed to do, which is form a clot, right? If you cut yourself, you get a clot. You want to have the clot. You don't want to bleed to death, right? So the body's doing what it's supposed to do. It's making a clot that seals this tear. But in the same time, it's closing off the artery and causing a heart attack. Not good. Not good. This is another kind of picture of that. So the discovery made back then was that the arteries or the lesions that caused heart attacks were not necessarily the ones that caused the most narrowing in the vessel. Actually, it was the younger ones. It was the young, wild ones that were still growing and uncontrolled and would cause that tear to occur. Another important feature. So the majority of blockages that cause the heart attacks were less than 50% narrowed by imaging. Okay, so the folks in Boston were working with a group at MIT looking at the wall of the artery using technology that looked at the metallic fatigue that you tested airplane wings with to see if you get fatigue of the artery and it would break down when the blood pressure went up high, for example, that it would tear the artery. But that kind of study did not bear out. And the reason was that it would take 10 times the normal blood pressure levels to achieve the degree of pressure that would tear the artery. So that didn't work. So the fallback was to look at what's going on in the biochemistry of the artery. And in the biochemistry of the artery, the theory that still holds till today, as far as we understand, is you have an inflammation in the wall of the artery with macrophages, which are cells that go to clean up the junk. You want them there. But they also bring their own baggage with them, and the baggage they bring with them is enzymes that digest. That's what they do. They go in and they digest stuff, okay? They digest bugs. That's what they do for a living. They digest foreign particles like carbon and other things. So they're cleanup. They're scavengers. But they also leave behind some junk that not so good. And the stuff they leave behind are enzymes that can digest the cap that prevents that material from opening up and tearing the artery. So basically the tear would occur here because of the digestive material that is being released into the tissue from the inflammation by those macrophages. Okay, so this is all wonderful and good. The problem is that nobody actually linked a heart attack or a tear to that actual digestion of the cap. It's a good theory, makes lots of sense, but that the quid pro quo, the yes and no, if I'm here, this happens, was not there. Cause and effect. So we continued to look, and I moved from Boston to Michigan State, and then we continued the work in my lab, and we made a discovery. And here's the discovery. So if you look at an artery that's caused a heart attack in a patient that died, you'll find that, like the other pictures, we have a clot that forms here, and then you have this pool of lipid or fat and gruel in the wall. But then there are all these little flaky things here. You see those pretty little things like here? What are those? So for the last 300 years, pathologists have looked at this and said, oh, yeah, this is cholesterol crystals that are sitting there because there's plenty of cholesterol here. And the cholesterol actually has dissolved because when you treat the tissue to cut it and make and process it, you put alcohol to make it stiff so you can shave it. Otherwise, you can't process it. Okay? Anybody who's worked in the lab knows that. And it's been done for the last 300 years. And nobody asked any questions. It's just the way it's done. Okay, that's fine. We know that that's the case. But what's their role? Do they have any role? And if you look at the literature, everybody says, oh yeah, they're inert. They're just sitting there. That's it. And this has been the status quo. Now, I'm going to involve you as an audience for a moment and see what you think. So let's look here. If you see look in the eye of some of your neighbors, you might find that they have this kind of white milky material around the iris. And I've done that at cocktail parties. I'll go up and look at, and people say, what are you doing? Get out of my way. But actually, you know what this is? This is this. It is this. And this is all cholesterol crystal that's deposited in the eyes. Now, as we get older, that can happen. UV light can cause the same kind of damage, so don't panic if you have this. Medical students go through this syndrome all the time. We were having this conversation at dinner. But it's real. If you find this, it's not something that you want to ignore, especially in somebody who's relatively young, like in their 40s. That's young. All right. Another place that cholesterol seems to like to deposit is in the tendons. Look at these. This is a patient with what we call familial hypercholesterolemia, which means they've got plenty of cholesterol depositing everywhere. And it's inherited. And there are communities in different parts of the world where this is very common because of close intermarriages. So these recessive genes will pop up. I don't know about Grand Rapids. Do you have that problem here? I grew up in a community that actually has this problem. And look at these. These are huge cholesterol crystal deposits in there. Now, let's go back to the previous picture. What is the common link between these things? You see here, you have the cornea of the eye. You have a tendon xanthoma, which is a fancy Greek name for the tendon. And then if we look at the arteries again, and we stain with Verhoef Van Giesen, which is a stain after Mr. Van Giesen, and it stains the elastic tissue in the artery, this dark black color here. So what's the common theme? Audience. Let's look again. Huh? No, of course, there's cholesterol in all of them, but what is the common theme? Let's look again. Cornea of the eye, tendon xanthoma, elastic tissue in the artery. What's the common theme? Pardon? I can't hear. Circular? I mean round? Shape? Interesting. I never thought about that. Thank you. So what do you think? What's the common denominator? Many of you are biologists. Now, put on your biology hat for a minute. Right? What's the theme? What's the common denominator between the tissue in the cornea, the tissue in the tendons, and the tissue in the elastic of the artery of the heart? Yes, it's the connective tissues. This stuff is attacking the connective tissues. It's depositing everywhere. So when we looked at the arteries, I said, you know what? The same thing's going on in the arteries as we're seeing in the corneas of the eye. That cholesterol is depositing and crystallizing the same way in all the connective tissues. Okay? So how does a plaque rupture then? So we have all kinds of things. We already said we have the inflammation that's going on. It's a spear, it's a snake, it's a tree, it's a wall. And this is what we do in science all the time until light shines up. And the light came to us and we said, okay, does cholesterol expand in volume when it crystallizes from a liquid state to a solid state like ice and water? Does it expand? So there was one of the fellows who's in training with me, and I asked him that question. He's a very smart guy. And he said to me, well, you know, there's only one element on this planet that expands when it crystallizes, and that's water. And we know that. You know, we're in the Great Lakes, ice floats, fish can live underneath. Basic. Most elements shrink, right? But the question is, and you have to be a bit of a nag when you're a professor, you get to be that way. But is there data to show that cholesterol does or doesn't expand? Has anybody looked at it? So we went through the literature and everything. No, there's no data. So you got to look, right? So there's no data. Let's look. This is the experiment. Actually, this is his hand, and this is the first experiment we did. This was a homemade video, so don't get a seizure looking at it. But here we buy cholesterol. You call Sigma and say, I want 100 grams of cholesterol. They say, fine, no problem, send us $100. We did. And you can dissolve it or heat it or melt it, whatever you like, and then put it in a graduated cylinder like this. And we're doing a high school chemistry experiment. This is not rocket science. This is very simple. And if you look at the meniscus of this line here, if you can see it, you'll see that there are a couple of things going on. This is crystallizing, as it should. Okay, it's going at room temperature. And is it going to expand above that meniscus line? And let's keep our eye. This is real time, by the way. And something's beginning to pop right over here. And if you look closely, you see two things. One is obviously there's volume expansion above the meniscus. But the other thing is that you see that the growing edge of the crystals has these hair on ends. Okay? All right, keep that picture in mind because we're going to go now to the next level and we're going to try and see what this means. So the expansion volume here is about 45% from its original volume. That's a huge expansion. Now, from other people's work, we know from biochemists that have looked at arteries, they have demonstrated that there is liquid cholesterol in the wall of the artery. We know that. So, a couple of things. One is that as the cholesterol crystallizes from a liquid to a solid, it expands in volume. The more there is to start off with, the greater the expansion and the more rapid the rate of expansion, time-wise. And if you fill a tube up to the rim, it will grow above it. And if you do scanning electron microscopy, my goodness, look at those hair on ends. They're actually sharp, nasty little crystals that will perforate a membrane similar to the membrane of the artery. And what we used here is rabbit pericardium. It's collagenous tissue, similar to the elastic tissue that's in the arterial wall. Just to demonstrate that the power within the crystallization process will perforate, and you can see it by naked eye. You can see the crystals perforating, and when you scan them, you see that they clearly go right through. Wow. That is a finding, right? Now, if you took this tissue here and processed it in the standard way that we process tissue, which is you put them in 100% ethanol, graded up to 100% for an hour or 3 hours, depending on protocols, what do you see? Nothing. It's dissolved. The cholesterol is totally dissolved by the alcohol. Okay, so we decided not to use alcohol, but to dehydrate the tissue in air initially. And then you can use it, you can dehydrate by vacuum, and both are acceptable. So you say, okay, this is wonderful news. We have a great benchtop experiment. Nobody's ever shown this before. Wonderful. So what? So we send this into Nature, and I send it to Science, and they said, well, so what? Who cares? What does this mean? Well, I used to be a pathologist, so I went back down to the autopsy suite, and I said to my colleague there, I said, by the way, can I have a little piece of that artery so I can test it the way that you guys don't? She said, sure, here. Okay, so here's the first case. This was a 35-year-old male who died in the emergency room, came in with chest pain, actually abdominal pain, which occasionally will happen with heart disease. And this is a scanning electron micrograph at low power below where the heart attack occurred, below where that tear occurred, okay? If you remember that tear from the earlier pictures. And if you don't use alcohol in the processing, you will find that the whole surface of that artery is studded with cholesterol crystals perforating their way through the intimal surface. The whole thing is studded. If you look at the actual site of the tear, which is here, and I painted it to show you what we're looking at. So if you shave the top of that artery, you'll find that the middle of it is filled with a clot, which has caused the heart attack. And then the blue is all the plaque that's formed in the artery, and the green is part of the plaque, but it's the place where the tear occurred. Here, this is one edge of the tear, and this is the other edge. All these little black dots here, the entire surface is studded with cholesterol crystals perforating their way into the wall of the artery. This was another case, a 57-year-old female patient who didn't feel so good. She went home, she went to bed and slept and never woke up. And this is her artery, and this is the tear. This is the right coronary. And the entire surface of that plaque is studded with crystals perforating their way through into the plaque, into the wall of the artery. More examples. And this is for comparison to show you what a normal artery should look like. This is the smooth endothelial lining of a normal artery. This is what you would see where there was an event. Now, the interesting thing is, when we sent this to publication, they said, you know, you're messing with the standard protocol. You did not use alcohol. Yeah, of course we didn't use alcohol. We wouldn't see anything. But we don't accept that, okay? So we took arteries from the operating room, directly from patients who were having endarterectomy for stroke. And we took pieces of the plaque that they would normally throw away or give to the pathology department. And of course, these are approved all by our, IRB and stuff. And we just kept it at 37 degrees, put it under a microscope at 37 degrees, stained for fluorescence of cholesterol crystals. And you see the crystals are perforating the entire surface of the artery. If you scan the same arteries, you'll see how prominent the crystals are. I mean, they form layers and layers and layers of just huge amount of stuff. So much so that if you take the whole segment that's taken out of a patient's carotid artery, this whole segment, which is about a centimeter or so, this entire surface looks like this, just studded. It's a jungle of cholesterol crystals. Now, it's always important to have somebody corroborate your work, okay? Because then you're a lone voice in the wilderness, and sometimes I feel that all the time. But this group at the Mass General Hospital in Boston used a different technology from us. What they did is they took what is known as micro-optical coherence tomography. It's a laser technique where you shine the light on the tissue, And it's fresh tissue. It's, you know, not altered in any way. And you can do microscopy by getting the reflection of the light back into the optical system, the coherence system. It's like a CAT scan, a high-grade CAT scan of tissue, basically. And what they showed was the same thing that we've seen, the crystals. This is the cap that we don't want to digest. And these are the crystals perforating their way through the cap. And this was published in Nature Medicine, which is a highly respectable journal. And they quoted our work to confirm that this is what they saw as well. Now, scanning electron microscopy, and I do a lot of that, is a very, very nice procedure because it shows you details that you really don't see with many other techniques. So this is a spider. It was a tiny itsy bitsy spider. And if you're aeronophobic, don't look at it, but it is extremely highly detailed stuff that you can see with that. So, okay, let's go back to our patient. You know, we've jumped back and forth, back to the patient. So in this particular patient who had died from a heart attack, we took the artery, split it in half, processed half of the same piece of artery with alcohol or ethanol in the standard method. This is the best crystal-looking picture we could find in 7 arteries that we treated this way. This is the same artery, same piece, mirror image, cut to show you that if you don't use alcohol, this is what you see. If you take cholesterol crystals, just off the shelf, put them in this strainer, and process the crystals the same way that we normally process tissue, this is what you end up with at the end of the day. Standard techniques. Now, there's been a lot of data over the years that have shown that alcohol actually does have, in moderate, and I underline moderate use, does have some protective effect on heart attacks and strokes. And this is out there. People drink wine all the time and say, is wine better than beer? Is it better than other drinks? It's really all the same thing. So the question is, yes, it does have perhaps some effect. I do not recommend to my patients to use alcohol to treat this condition. You do not? I leave it up to them. So, what causes the crystallization in a patient? Obvious question, right? You want to know that. I know you want to know that, right? Right, because you're all interested, you're science, thinking science. What causes this thing, right? I wanted to know that. Well, you don't need to go very far because even your high school chemistry will answer a lot of these questions. One is saturation. The more you have, like we showed in the tube, if you have more cholesterol, the crystallization occurs more rapidly, remember, and the amount of displacement is greater. And we know that in arteries of the heart. The bigger the plaque, the greater the risk for a heart attack. Not the stenosis. Big difference. Temperature. We know that heart attacks occur in the early morning hours, right? Is the core temperature different in the early morning hours than it is later in the day? Yeah, it is. By how many degrees? 1, 2 maybe? It is. pH. Acidity. Could it have an effect? How about pressure? External pressure. Yeah. All these things do have an effect. How about external effects? Inflammation and vasospasm of the artery. We'll come back to that. So if you take test tubes, and this is at 37 degrees, not melting it like we did before, and this takes 24 hours to occur. And if you put different amounts of cholesterol in corn oil, which is a standard technique that's out there, you'll find that the more cholesterol in the tubes, the greater the crystallization. Simple. And it's the same kind of crystals that we get. What about pH? As you increase the pH, same thing happens. There's greater crystallization and volume expansion. What about temperature? I'm sorry, this is saturation. What about temperature? Same thing. Even within the physiological range of temperatures, you'll find that between 36 and 40 degrees centigrade, even a 1 or 2 degrees difference makes. And if you combine the two, if you do temperature and saturation, it even goes much, much further up. So this is beginning to make sense, that heart attacks are occurring in the morning or early hours because maybe some temperature change, perhaps. So we did a study looking at patients who had heart attacks and who died with a heart attack. And we look at 19 autopsies in patients who died of a heart attack and patients who died of other causes but had blockages in their arteries, just like those who had heart attacks but didn't die of it, okay? And if you look at the presence of clot, you'll find that those who had heart attacks all had clots, or the majority had clots, whereas those who did not have heart attacks had no clots. We know that. This is nothing new. But cholesterol crystals were present only in the 19 patients who had heart attacks, and none of those who died of, say, sepsis or pulmonary embolus or car accident, who died of many other reasons, who did have plaque but did not have a heart attack, had no crystals. When we look at patients who had strokes or had carotid stenoses, we looked at 70 cases. In patients who had symptoms of stroke, like blindness or loss of speech or dizziness, 80% had thrombus. Those who had no symptoms had 35% had thrombus. But look at the difference here. 55% of these patients had cholesterol crystals that were extensive, and only 21% of these patients had crystals, extensive crystals. And if you look at 0 crystals versus +3, meaning very few crystals, a few crystals, more crystals, everywhere, like I showed you, the jungle of crystals. And the more crystals you had, the more clot you had, the more crystals you had, the more thrombus you had. The larger the plaque, the greater the amount of crystals. So the summary of that data is that crystals were associated with plaque rupture, with thrombus formation, and neurological symptoms. Now, let's look at alcohol. The legal limit is 0.04. 0.08. Sorry about that. Many of you may not make it home tonight. So legal limit 0.08, you will find that it does actually have an impact on dissolving cholesterol. As you go further up the line, you'll find that obviously you have more impact on dissolving it, but 0.25, you're anesthetized. You're probably thinking of how it was in the Civil War when they chopped people's legs off who were injured. That's probably where they were at. Lethal levels is 0.5. Now, is this a new concept? No, it is not. We know from many, many other medical conditions that crystals cause issues, cholesterol crystals. So Hollenhurst, back in the 60s, showed for the first time that patients who had carotid plaque will shoot up cholesterol crystals, and they define them to be cholesterol crystals, to the retinal arteries in the eye, causing blindness or temporary blindness. They can shoot them to the leg and cause what we call livedo reticularis, and this comes from the aorta. Or they can shoot them to the kidney arteries and damage the kidneys severely, or even gangrene. So this idea is not entirely new. So I was giving a similar talk to this back in the day, and somebody in the audience who was working on uric acid said, you know, uric acid crystals cause this inflammation and activates dendritic or macrophages. cells, and there's a paper in Nature, and there's another one here in Nature. Let's look at your crystals and see if we get the same thing out of them and if they use the same biochemical pathways. Let's look at uric acid, crystals in the joint. Now stretch your imagination a bit. If you cut through a joint, does it look like a plaque? Yes, it does, for those of us who like to think like that. And in fact, the joint is markedly injured and damaged by the presence of uric acid crystals. So can crystalline cholesterol act as an endogenous danger triggering inflammation via inflammasome? And the answer is yes. And this is the paper that we published in Nature with Peter Duell and Ike Latz from Germany. And between the three of us, we demonstrated a couple of things. One is that this is control. This is in mice that have plaque. Even within 2 weeks of being on a cholesterol diet, you start seeing crystals. And this is a new idea because these were thought to occur late in the process. But look how early they occur, within 2 weeks. At 12 weeks, they're all over the place. I'll skip this for a moment and just get to the summary because I know you have questions, and tell you that cholesterol crystallization is critical in plaque rupture, which has not been recognized in the past. The amount of cholesterol in the core is the determinant of the rupture. Ethanol dissolves the crystals. Statins, and I didn't get into that, are the drugs we use frequently for lowering cholesterol, dissolve cholesterol crystals. And distal embolization, of course, causes further injury. And I'm going to stop here because we're running out of time, but I do want to show you one more thing, that this process may be more universal than is appreciated. This is a thyroid nodule in a patient who died, one of the patients that we had who died with plaque rupture and cholesterol. This is cholesterol crystals inside a thyroid nodule, and they're in many other places in the body. So this is what we're talking about. You invite your friends and relatives to your home. You don't have cold beer. You put a few in the fridge. You get involved in a conversation. You forget your beer in the freezer, and you come back, and it looks like this. I didn't use real beer. I just used water. But this is what we think is going on. It doesn't negate what's already been described in terms of inflammation and other aspects. It just takes you that one step beyond and shows you that the process that leads to that kind of event that's unpredictable is based on local chemistry within the arterial system that leads to these events based on crystallization of the cholesterol. So I'll stop here and take questions. Thank you so much for your attention. Yes?
Does good cholesterol crystallize? Does good cholesterol crystallize?
It should.
So
All cholesterol crystallizes. But here's the point. When you say good cholesterol, you're actually referring to the protein that carries cholesterol. You're referring to the high-density protein, HDL, that carries cholesterol. So there's no such thing as, when it comes to this element, of good or bad cholesterol, in the sense that it doesn't matter what we're dealing with. The good cholesterol and the bad cholesterol, it's the molecule of cholesterol. Does that make sense? It's not the carrier. The good cholesterol, when we say good cholesterol and bad cholesterol, that's really a misnomer. Good cholesterol is the protein that takes the cholesterol out of the artery back to the liver, whereas the bad cholesterol tends to deposit it anywhere it feels like. Actually, it's not a cholesterol. It's the molecule that's carrying it. And that's how we label it. It's actually not the cholesterol itself. Does that make sense? Okay, thank you. Yes?
When that experiment was done where the cholesterol expanded, you were lowering the temperature? Were you freezing it?
No. It was at room temperature, but your question is very appropriate. What is the melting point of cholesterol is really what you're driving at. The melting temperature is 145 or 48 degrees centigrade. That's pretty high. So you can argue then, oh, well, gee, you know, when is that ever going to happen in the natural body? That's never going to happen. But we've done the same experiments at 37, but then it takes longer. Then you have to dissolve it in oil and look at the saturation like I showed at 37 degrees, and it will crystallize the same way.
So is that the theory why heart attacks may occur in the early morning because the temperature's lower?
Yes, that's our answer to that question. It may not be the only element. You know, biology is very complicated. There's no one single answer to a problem. It's usually a conglomerate of things that come together, which makes it chaotic, you know, for us, because we have to tease out all the little pieces that lead to that point.
Doctor, Doctor, can you hear me?
Yes.
Doctor, you talked about gout and the crystallization from the uric acid.
Right.
And you also talked about the crystallization with cholesterol. Is there a link there? And does somebody with gout have a higher propensity to have a stroke or a heart attack than somebody else?
So everybody heard that question, right? So over the years, the risk of gout as a risk factor, like cholesterol, has been tossed around back and forth. There have been studies that have supported the fact that gout is a risk factor for coronary disease and heart attacks and strokes, and data that has gone the other way. In fact, the last paper in Lancet that came out a year or so ago negated it. The reality is that gout probably does similar things to cholesterol. It is not easy to test gout or uric acid or monosodium urate the same way we tested for cholesterol. And we've tried. The problem is that the way you look at the uric acid crystal is by its refraction of light. And the refraction of light by cholesterol and uric acid is almost identical. It's very hard to separate the two out. And it's very hard to make uric acid crystals. So because of the technical issues, we haven't been successful in doing what we've done with cholesterol crystals as we have with, as you're asking, as with gout. But let's think, step back for a moment and let's think. Is crystalloid disease a foreign thing to humans? No. Gallstones are pure cholesterol crystal. They're pure cholesterol crystal. Kidney stones, even the calcium kidney stones, at their core have uric acid as the nidus around which the calcium forms. Now, calcium also forms around cholesterol. So we do see calcium building up around those arteries that have plaque in them. But it's probably because the cholesterol acts as the nidus on top of which calcium will go in and deposit. So these crystals attract each other in kind of a funny way.
Thank you, Doctor. You discussed that statins were a primary treatment for high cholesterol. Can you talk a little bit about their use and the side effects that seem to occur with them
Sure.
for a lot of people?
So statins have been around now for about 20 years or a little more, actually. Started in Japan, actually, and they're derived from a fungus, and like many antibiotics and so forth. And it was demonstrated that they're very effective in lowering LDL levels. And they're HMG-CoA reductase inhibitors in the liver. They increase the activity of the receptors in the liver to capture the bad cholesterol, meaning the cholesterol that's attached to the bad carrier molecule. And they are very effective. They're the most effective drug we have today in lowering cholesterol. And that's wonderful. They've made a huge impact. In fact, they've reduced not only heart attack rates, but they've reduced the angioplasty procedures that need to be done. Bypass surgery has dropped a tremendous amount. Surgeons are going out of business, essentially, because of statins. So they've been extremely effective. Now, nothing comes for free. There's always some downsides to everything. And the downsides, the number one downside for statin is been this kind of achiness that develops. And interestingly, some statins have that more than others. Some statins are fat-soluble molecules that penetrate the muscle and other tissues more effectively, like atorvastatin or like simvastatin. Those are more lipid-soluble statins, whereas water-soluble statins like Prevacol or rosuvastatin tend to be maybe less in terms of their symptoms. But people argue back and forth. Are they the same? Are they different? Some people do better with one than the other. That we know clinically seems to be the case. Now, the single most serious side effect of all statins is breakdown of muscle. And that can be lethal. It's extremely rare. It's like 1 in a million, where the muscle actually breaks down. And that can cause kidney damage, and it could be irreversible, and it could cause death if it's unrecognized. So, but it's extremely rare as a side effect. Those are kind of the major issues with statin, but otherwise they have been a very effective treatment modality that we have. Now, if you compare it to other drugs that we've had over the years, like niacin and the resins, which are drugs that sit in the gut and sort of soak up the bile that has a lot of cholesterol in it, and then shoves it out the door. Said, we're gone. Those are not as effective, but those were the earliest drugs that we had. And all drugs, and it doesn't matter of what category they are, lowering the cholesterol has a positive impact. Whether you do it by diet, whether you do it with drugs, whether you do it with whatever you can bring it by losing weight, all those will eventually lead to improvement in risk. But the most powerful tool we have today is still statin. Now, there's one important caveat that patients don't quite always get, and even some doctors kind of get lost in this one. And that is that if you look at your total cholesterol in the serum, 85% of that is manufactured by your liver. It is not driven by the food you eat. Only 15% of the cholesterol that you eat, that's in your system, that's circulating in your blood, is actually derived from a diet. Now, it doesn't mean that we don't recommend diet and exercise, because all those do benefit, no question. But rarely are they a substitute alone to lowering cholesterol with other means because of the genetic makeup of the liver. And as we get older, when you're first born, your bad cholesterol, the LDL, is about 30 milligrams per deciliter. We're born with about that level. And when you get to about 50 years of age, your average LDL level is about 130 to 150. That's how much the liver has become efficient in making cholesterol. And you say to yourself, well, gee, you know, if I lower my cholesterol, what's going to happen to my cells? Because all the cells are made of, the cell membranes and everything is made of cholesterol. Is that going to damage my neurons? Is my memory going to go? And there are people, and we can come back to that, that do have some memory issues that occur with statins. And it is dose related. So the issue there is, okay, what do you do? I mean, there's a trade-off. If you have severe heart disease and have had heart attacks, there's no question there's an important role for statins. So I hope this kind of gives you a global picture of where we are today.
In your examples of the tendon and the eye, you pointed out
Your microphone isn't on, I don't believe.
your examples of the tendon and the eye, you pointed out that cholesterol crystals collected there. Why would cholesterol collect in connective tissues?
Good question. I don't know the answer to that. I just saw it. I don't. I don't know why cholesterol is attracted to these tissues, why it likes to deposit in these tissues. Maybe that's a project you'd want to do. My plate is full. I don't know.
Relative to the number of people who have cholesterol, high cholesterol, serum cholesterol, and it's a huge percentage of the population, is there any physiologic advantage? In other words, from a biological evolutionary standpoint, why do we have such high LDL? It increases with age. Why is it there?
Now you're beginning to test my theories. Okay, you know, when humans evolved over time, they got smarter, their brains got bigger. So the theory behind that is that we became meat eaters when that happened. Now think about that for a moment. What does meat have plenty of? Yeah. So what's this inside here composed mostly of? It's fat. It's fat and water, and a few neurons floating around in there. But there's a huge amount. I mean, one of the richest organs in the body, perhaps equal to the liver, if not more, of cholesterol is the brain. And I'll leave it there. Okay, silence means we're done. Thank you.
We'll do one more.
One real quick one. Should we all be on statins?
Oh, you're really pushing the envelope here. Do you know the lady in the back there? I'll give you an example, and I won't answer your question, but I'll give you an example. So we had a patient who had a plaque that we took out of the carotid, and we did scanning electron microscopy. The surface of the plaque was perfectly normal. The intima of the lining with the endothelial cells were absolutely pristine. But if you looked 1 millimeter below that pristine wall, you would find there is a jungle of cholesterol crystals. So I asked myself, and I don't know the answer, is at what point in our aging process are we supposed to start worrying about this? Is it in youth? Is it as we're in middle age? Is it as we get older than middle-aged? Personal need for that, yeah. But we don't know at what point. We don't have that evolutionary trend, meaning in a single person's life, where is it best that we should intervene and prevent this from becoming a problem? It doesn't have always to do with the serum level of cholesterol, and this is very important. The serum level of cholesterol is a secondary marker. The disease is in the wall of the artery, like I showed you. The level in the serum doesn't always correlate well with the disease in the wall. And that's genetic. Some people allow cholesterol maybe to come in more than others. The majority of heart attacks, the cholesterol level is normal. I mean, for our society, it's within normal limits. So it's a very challenging issue as to when do you start treating, who do you start treating. So the American Heart and the American College of Cardiology and the latest recommendations that have come out from the NACP, which is the NIH government sources, and I Don't know how accurate those are always. But their recommendation is you treat the patient. You treat the patient based on their risk. So we used to use blood levels of cholesterol. So we used to use, if somebody's cholesterol was over a certain number, that's when you start treatment. Today, the drive is no, you treat the patient who is at their highest risk. And then you calculate risk based on age, gender, cholesterol too, but also their family history, and are they sedentary, are they not sedentary? All those are formulated into a fancy formula that you stick in all these numbers, and at the end it tells you risk for 20 years of having a heart attack are within 10 years or within 20 years. The first formula that came out of Framingham in Massachusetts, the Framingham study that looked at this. It was an epidemiologic study, and then they finally derived those numbers. There are now several more refined formulations that are being used. But the basic issue is still the same. High risk, treat. Low risk, leave alone.
Is 200 still the benchmark for high cholesterol?
We're off benchmarks. We're off the gold standard. We're gone. Yeah, it's treat the person. We're off the gold standard. Thank you.